What is obsessive compulsive disorder? Obsessive compulsive disorder is a chronic illness that can cause marked distress and disability. It is a complex disorder with a variety of manifestations and symptom dimensions, some of which are unrecognized. Early recognition and treatment with OCD-specific therapies may improve outcomes, but there is often a delay in diagnosis. Patients can experience significant improvement with treatment, and some may achieve remission. Recommended first-line therapies are cognitive behavior therapy, specifically exposure and response prevention, and/or selective serotonin reuptake inhibitor, which is SSRI. Patients with OCD require higher SSRI dosages than for other indications, and the treatment response time is typically longer. When effective, long-term treatment with SSRI is a reasonable option to prevent relapse. Patients with severe symptoms or a lack of response to first-line therapies should be referred to a psychiatrist. There are a variety of options for treatment-resistant OCD, including clomipramine or augmenting an SSRI with an atypical antipsychotic. Patients with OCD should be closely monitored for psychiatric comorbidities and suicidal ideation. What are the classic symptoms of OCD? Recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. Repetitive behaviors, hand washing, ordering, or mental acts, praying, counting, repeating words silently that the individual feels driven to perform in response to an obsession or according to the rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or clearly excessive. The obsessions or compulsions are time-consuming, take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The obsessive-compulsive symptoms are attributed to the psychological effects of a substance, a drug abuse or medication, or other medical condition. Some common symptoms in patients with OCD are fear of harming others, recurrent violent images, fear of being contaminated or contaminating others, fear of being contaminated by germs, infections, or environmental factors, fear of being contaminated by bad or immoral persons, recurrent worries about doing things incorrectly or incompletely, thereby negatively affecting the patient or others, thought about being immoral and internal damnation, fear of making inappropriate comments in public, recurrent thoughts about being a pedophile or sexually deviant, recurrent thoughts about acting sexually inappropriate towards others, fear of a certain bad number or colors, recurrent thoughts of needing to do things in a balanced or exact fashion. What treatments are available for OCD? Once OCD is diagnosed, it is important to provide the patient with information and support. Patients and family members should be educated about the chronic nature of OCD and the importance of self-management skills. Evidence-based medical and behavior therapies can reduce the severity and frequency of obsessions and compulsions, and can reduce remission in some patients. Because it may take weeks to months for these therapies to become effective, physicians should inform patients about this delay in treatment response and encourage adherence during the early phase of treatment. It is helpful to quantify the severity of symptoms and impairment before and during treatment. This may be done using standardized rating scales or by patient report of the time expended on obsessions and compulsions and the level of distress they cause. The Yale-Brown Obsession Compulsive Scale 2nd edition is a reliable tool for measuring OCD symptom severity and is available at their website. Patients should be assessed for suicide risk and presence of comorbidities throughout the course of their illness. Treatment is indicated when OCD symptoms impair the patient's functions or causing significant distress. Reasonable treatment goals are spending less than 1 hour per day on obsessive compulsive behaviors and achieving minimal interference with daily tasks. Psychiatric consultation is recommended by patients with severe OCD as measured by the YBOCS2. Cognitive behavior therapy, specifically exposure and response prevention, is the most effective psychotherapy method for treating OCD. Patients are exposed to anxiety-provoking stimuli and learn to not perform compulsive behaviors in response. Ideally, CBT should be administered by a trained healthcare professional in an individual or group format. Although studies have suggested that self-directed exposure and response prevention combined with motivational interviewing may be effective. Incorporating motivational interviewing may cause engagement with therapy and improve its effectiveness. There is no evidence for the use of psychodynamic psychotherapy or talk therapy to treat OCD. OCD has a highly selective response to serotonergic medications. Clomipramine, a tricyclic antidepressant with a strong serotonergic effect, was previously the first-line pharmacologic treatment for OCD. However, because of concerns about its safety and adverse effects, selective serotonin and reuptake inhibitors are now preferred for initial therapy. A Cochrane review confirmed the effectiveness of SSRIs for the treatment of OCD. If medical therapy is successful, it should be continued for at least 1 to 2 years, if not indefinitely. Relapse prevention with continuous SSRI therapy is a reasonable treatment goal. If the patient chooses to discontinue pharmacotherapy, the dosage should be gradually tapered over several months and the original dosage resumed if symptoms worsen. The response to psychological treatments may last longer than the response to medications. Periodic booster sessions of exposure and response prevention are recommended to lower the risk of relapse when psychological therapy is discontinued. If an adequate trial of SSRI or psychological therapy does not result in satisfactory response, combined treatment is an option. If the patient prefers to continue with medical therapy alone, a trial of different SSRI is warranted. If there is no response to trials of at least 2 SSRIs, the patient should be referred to a psychiatrist. There are a variety of other options for patients with treatment-resistant OCD, but the evidence for most therapies is limited. Some studies support the effectiveness of serotonin. Deep brain stimulation has had promising results for severe treatment-resistant OCD, but it has been studied in only a small number of patients. This treatment is used as a last resort and has had limited FDA approval under the humanitarian device exemption. Do obsessions always come with compulsions? If it is an official diagnosis, then yes.